welcome all to this webinar roundtable discussion, which is a continuation of discussions from the EULAR, European Alliance of Associations for Rheumatology Congress, which was held at the beginning of this month in June. We will discuss new trends and data presented at the EULAR Congress, as well as a discussion on the promising and emerging treatments for a host of rheumatic diseases. This educational activity has been supported by a medical educational grant from Viatris, and this webinar is intended for healthcare professionals only. My name is Dr. Julianne Locke, and I'm delighted to host this roundtable discussion along with three very esteemed guests from the fields of rheumatology and gastroenterology. First up, we have Professor Dr. Rika Alten. She is head of the Department of Internal Medicine, Rheumatology, Clinical Immunology, Osteology at Schlosspark Klinik in the University of Medicine Berlin in Germany, where she also serves as director of the Rheumatology Research Center. For many years, she has specialized in rheumatology and has a research focus on the development and systematic evaluation of biological and immunomodulatory treatments for rheumatic diseases, and has been the lead investigator in novel clinical trials. She has published over 200 peer review papers, along with various book chapters and reviews. We are also joined by Dr. Richard Conway. Richard is a consultant rheumatologist at St. James's Hospital in Dublin in Ireland and has recently been appointed as Clinical Associate Professor at Trinity College Dublin. He completed a PhD in giant cell arteritis at UCD in 2017, and he has authored more than 150 peer-reviewed publications and 3 book chapters. His research interests include interstitial lung disease in systemic rheumatic diseases, vasculitis, and polymyalgia rheumatica. And to provide the thoughts from a gastroenterology point of view, we will hear from Professor Silvio Danese. He is a gastroenterologist and professor of gastroenterology at Vita Salute San Raffaele University and IRCCS San Raffaele Hospital in Milan, Italy. He is the head of gastroenterology and gastrointestinal endoscopy unit there. His main area of research is the fundamental mechanisms underlying IBD pathogenesis, and his clinical work is primarily in treating IBD patients. He has published more than 700 peer-review papers and was, until 2020, president of the European Crohn's and Colitis Organization, ECHO. So after this roundtable discussion, we will have a live question and answer session. So please do put any questions you may have in the question box that you will see at the bottom of your screens, and I shall endeavour to have our experts answer as many as time allows. So let's start off with some discussions. I guess one thing that was a huge highlight at the Congress was with regards to biosimilars, and it was the discussions on DanBio. So what do you think were the most important, I suppose, aspects that were presented there? Like, what's exciting you most about DanBio? I think we'll start off with Richard for this one.
Great. So I might just give a brief overview of this study for anyone who might have missed it. So it was an oral presentation presented by Dr. Nabi. DanBio is the Danish biologics registry, and this is a study kind of nested within that. It's looking at patients with rheumatoid, psoriatic arthritis, and ankylosing spondylitis who switched infliximab biosimilar. So I think the background to this was that Denmark, when infliximab biosimilars came along, mandated a nationwide switch, and now they've mandated another switch of biosimilar to biosimilar for everyone on the drug. So in this study in total, there were 1,600 patients who were switched, and they followed them up for a year after the switch. We found a couple of very interesting things. So there's kind of 2 separate groups of people. There were people who are on infliximab originator product who were switched to biosimilar and then switched again. And then there are people who were only ever on the biosimilar and switched to the second biosimilar. And they found differences in retention rates between these 2 groups. So they were higher for those who were originally on originator infliximab. So people who had kind of already successfully switched, they had retention rates of 92%. And people who were only switching from their first infliximab biosimilar, they had retention rates of 82%. So quite a difference there. And then they went on and did multivariable modeling on this. They found 3 factors which predicted retention, and 2 of them were things we'd expect. So disease activity. So if you're going in with higher disease activity at the time of switch, not surprisingly, you were less likely to stay on the switched agent. And methotrexate was the second one. So, methotrexate helps with drug retention, and seemed as well here it was protective for retention. And then the being on the originator previously or not was the third factor. So it held up in the multivariable modeling as well. I think this is very interesting, this study, for two reasons. One, we are seeing a biosimilar to biosimilar switch at a very large scale, and proving that it seems to be effective and safe, kind of as we would have expected. And the other thing, I think the difference between the two groups is quite informative. So the fall off in the group who are originally on the originator, switched to biosimilar and then switched again, is kind of around the same as what you'd expect for loss to a biologic over a year, just under kind of 10%. But then there is this extra bump in the group who are switching infliximab for the first time. I think this extra bump probably represents something of a nocebo effect in these patients.
Actually, I would like to add something. I think we clearly see from this very, very nice study, but the Danish people are lucky because they can use all the data from the insurances that are linked to the prescriptions. Because in Germany, for instance, we have the rabbit registry, as everybody knows, but it's more difficult to collect these data. It's always dependent on the willingness of the physicians to deliver these data. And there is somehow a little register fatigue at the moment in Germany. So actually, it's very highly appreciated that we have these data. And we can also take into account that many of these factors are not drug related, but they are patient related. I think this is one of the most important information we can draw out of these analysis. And also, what I think Richard already pointed to is that disease activity is key. Disease activity indeed matters, and that if patients are in remission, they are somehow more happy with the disease control, I think. And so they are more willing to accept switches, I think. That is also a very important factor, also in my own experience.
So it's not so much that Danish patients are different, it's that they have better resources for tracking things. And I think that's something people should be quite aware of. Silvio, from a gastro point of view, how have you been finding, taking patients from an originator compound into a biosimilar?
I would say that gastroenterologists have been even more proactive than rheumatologists. For the first time, is the opposite, because the reuma has been always up front in the immune-mediated diseases. But for biosimilars, I think gastro are using now most of the time biosimilars. In my practice, I only use biosimilars. We have also a big Italian registry. We have published over 600 real-life patients multiple times over time. And I would say that the data fit very much with the DAN-BIO registry. That, of course, I would say that the quality of the Danish database is better because for us has been real life prospectively, but in general, the retention rates are very similar to what you would expect with an originator. And I think that after the launch that was in 2015, now after a couple of years, plus with all the evidence that we have in gastroenterologists are very, very, they don't even consider the originator unless there is a real price value for the originator as compared to the biosimilar. But we consider the products to be very effective in the same way.
So far at the moment, as far as just 1 second, as far as I overlook the market in Germany, there is less than 3% of adalimumab originators, which the data were collected by our pro-similar association. So that is really over the field of rheumatology and gastroenterology. And as Silvio pointed out, now that has really changed. In the past time, always the rheumatologists were the first, and now you took over. Really, I have to admit that.
We can give gastro a clap on the back for that. I suppose, I mean, this is the thing, isn't it? Biosimilars, they really are becoming now the kind of the go-to in a lot of places. And what we've seen from Dan Bio is, this idea of mandating changes to biosimilars. So let's explore it in a little bit more detail. Let's look at tocilizumab, my goodness, my apologies there, which is widely used in RA and juvenile idiopathic arthritis and joint cell arteritis. So where are we with biosimilars for that compound and other non-TNF inhibitors? Let's start off with actually Rika for this one.
Actually, as we participated in the real great trials, which led in the end to the approval of tocilizumab for giant cell arteritis, of course, we are very curious. And I remember the first trial, it was maybe the option trial where we had about 60 patients with the compound tocilizumab at that time. And the big first publication came together with Josef Smolin and myself in Lancet. And from that time, maybe we have treated more than 1,000 patients with tocilizumab. There were some problems with the gastros because there were some side effects in between, but these data were also nicely investigated by the registries. And in the end, tocilizumab is a very well accepted drug, especially more and more in giant cell arteritis, and also those patients who cannot tolerate methotrexate as a monotherapy. And so it's very, very encouraging that now we are going to have a new tocilizumab biosimilar. I think it's in phase 2 now. I have not seen phase 3 data so far, but I think it will not take long. I think the phase 3 is already underway. So that, yes, the companies who produce tocilizumab so far have to wear nice gloves to stay on board.
And I suppose, Richard, have you any additional opinions on that, or where you'd like to see a biosimilar in that field going?
Yeah, I'll add first of all, just the phase 3. One of the phase 3s they presented as a poster at EULAR, 600 patients, and as expected, it works. It's the same as the originator, which is fantastic. I think it's great that we're seeing this data come along because we've largely been confined to TNFs and rituximab. We've had rituximab biosimilar for a long, long time, and equally works very well. I'm especially delighted to see tocilizumab coming as a biosimilar. We had huge problems last year due to COVID and supplies of originator, and we had a lot of patients who couldn't get drug, including patients with conditions like giant cell arteritis where they really shouldn't be going without it. And we were particularly vulnerable in Ireland because we don't have any other IL-6 agent. They never entered the market here, so we just had tocilizumab. So I think having more options for patients is good, as well as all the other advantages that come along with biosimilars. And hopefully we will see more and more of these drugs coming along with their biosimilar versions.
And is it particularly beneficial to have a biosimilar for the juvenile patient? Is that a group that sometimes maybe gets missed out a bit with a biosimilar? Rika or Richard? Actually, Richard, you start off, sure.
Richard first.
So I think I don't know if it's particularly beneficial for them, but I think juvenile patients do sometimes get a little bit left behind, like the other typical groups that get left behind, pregnant women and people who it's more difficult to do trials in, or there can be problems doing trials. I think the juvenile group is always more emotive. It's always more of a challenge, almost to make any changes with all of the feelings that go behind having a sick child. But I don't think there's no reason why biosimilars shouldn't be just as effective for the juvenile population as they are in adults. I think it would be beneficial to have more and more data on this. So we'd a couple of more abstracts at EULAR on the juvenile population and looking at adalimumab biosimilars in particular. And again, very much mirroring the adult data that it seems as effective as originator adalimumab in these groups.
But tocilizumab is especially helpful for those patients with severe systemic features. And I have many patients who are really treated by us from teenage age via transition to young adults. And for them, we have seen really good results. And so it's always good to have an additional option for these long time patients, and hopefully the price will go down a little bit. That will be also hoped and expected by the healthcare system. Then we can really make the decision a little bit for more patients.
And you know, as it has been discussed in the past about with biosimilars, if you can reduce the pharmaceutical cost, you can then put investments into other aspects of patient care. So whether it be psychological support, whether it be, you know, personal training, exercising, so it can go to help the patient in other ways. I guess, Professor Denise, this idea of biologics being used in rheumatology and then heading into gastro, I know you're ahead of the game on the biosimilars, but where are we in terms of like the real world examples? Like, how are you finding it? It's particularly with having the Italian registry. How are you finding the uptake of biosimilars in gastro patients?
Yeah, I would say that in real world, now at least this is an example of either at the Italian but also the European level. With ECHO, we have a big registry, and we are trying to collect as much as possible the use of advanced treatment linked with real life data. And of course, these data are maturing, and we will start seeing papers coming out probably in a couple of years, because this was launched, and of course the uptake requires IRB approval and so on, but this is something that will become very big in the long run. But of course, it's a wishful dreaming. I don't know if you have a European registry from EULAR, for instance, or things like this, depending on the diseases, but this is something that I think is going to be a big resource.
That pan-continental approach to really share that information around a bit more. I mean, one thing about the biosimilars that was obviously there's been the DanBio stuff has shown the mandating. So if we start to see pharmacists automatically substituting a biologic for a biosimilar, you know, what might this mean to, I suppose, to you guys in your prescribing practices? And also the method of delivery, like if we move from, you know, if you've prescribed something as an intravenous, but maybe it's been replaced by a different initiation approach. So yeah, Rika, your thoughts on that?
We are going to have the law from 1st of July, but there are many people protesting against this law. And I heard from the lawmakers that even they don't know how they could realize the law, that automatic substitution will take place from the 1st of July. And there are many pharmacists who are not really interested, because also they don't have an advantage in changing one drug to another, because the differences in prices are definitely minor. So we all have to find a very good solution for our patients. And for patients, sometimes the substance is not so important, but the device might matter, because if they get a different device every 3 months, they get crazy. And we are going to have the nurses in the clinic to explain them how to use it, etc., etc. I think that is absolutely unnecessary. I think we don't need automatic substitution, because the price differences are not so huge that all this has its value for the patients and also for the healthcare professionals. I'm curious what the other colleagues are thinking and how the situation is in Ireland and also in Italy.
So I suppose that, Richard, that brings us on to you, really.
So yeah, I think like obviously the IV switching at hospital pharmacist level, if that had to be mandated, that makes perfect sense. But I agree, the subcut switching is a very difficult issue in some ways. In Ireland, we have a huge price difference. The originator to biosimilar is about a quarter of the price. So it's an enormous...
But between the biosimilars, the originator to biosimilar, that is 25 to 30%, but going from one biosimilar to another, the price difference, in my opinion, are not so high.
You know, yeah, absolutely are. As far as we know, although it's not quite opaque, the biosimilars are almost exactly the same price in Ireland. But we do still have very large numbers of people in some areas who are on originator product and not on biosimilar at all. Yeah. It's the distribution, so there are certain areas where nearly 100% are switched, and then there are certain areas where nearly 100% aren't switched for various reasons. But I agree, device-wise, it's going to be a very big hassle if that starts to happen. I also think it'll lead to a not insignificant amount of missed doses because patients just won't be able to do it, and we don't, with the new device, we don't have the resources to get them trained before their next dose is due, which will potentially have negative cost impacts if they start flaring, start being admitted to hospital because of their flares. So I don't know exactly why that's happening in Germany, but it seems a little bit misguided to me.
And Sylvia, what are your thoughts on this? If pharmacists did an automatic switch?
I would prefer no. I always like to have a discussion, and in general, I would say that the caring physician should be the only one giving the. Of course, this is an open discussion, but it's something that I would prefer not to have it.
And I suppose it kind of lends itself quite nicely to the nocebo effect. If I think I've been prescribed one thing and I rock up and my pharmacist gives me something else, like how might you like manage nocebo effects there, and the reluctance, I suppose, for patients where they go, oh, well, I thought I was getting this X brand and why am I being given something that's not the same name? So how would you manage that? Richard, let's start off with you.
So I think it's difficult. Nocebo effect. There's all sorts of different things playing into it and different factors at play. I think that, like this particular example of somebody thinking they're getting one drug and getting given something else that they've never heard of, that's in a certain person, that's guaranteed to cause a problem. So I think, as Sylvia was saying, a good discussion with the patient, explaining it in detail, addressing any concerns, will alleviate some of the factors, but I think there's always a kind of unmet need there, a challenge to overcome other things, and we're always limited by time as well. I think it can be very, very difficult in certain people to overcome the nocebo effect.
And Silvio, how would you manage the nocebo effect if you even in the switch, I suppose, from originator product to biosimilar? How do you address that with your patients?
So we have even make an international consensus together with Reuma, Derma, pharmacists, patient organization, psychologists, and basically the important thing is patient education. There has been a very nice study coming from the rheumatic literature showing that if you have a positive framing in the communication, this reduces the nocebo effect. So I think is like when you go to a restaurant and you are the customer and the waiter comes and he tells you, what do you want? A big chunk of hard to digest pork grilled or a nicely light, freshly catched fish? What do you answer? So that's the way you communicate to your patient, the way they will be mentally predisposed to a drug that objectively has no problems during the switch in terms of biomarkers that are objective markers of inflammation. On the contrary, the personal perception may change with the nocebo, and this is when the framing of the explanation becomes crucial. And that's why what we have done, what we have implemented in our practice is to have nurses that have been trained in specific communication skills. We have done these experiments at the beginning, and it has been very useful in the way the communication happens.
And Rika, I suppose, I mean, it's what, 2.5 weeks away until some of your patients might be going in and getting a switch at a pharmacy. Are you quite worried about this nocebo effect on your patients?
So we found our specific ways to avoid this because we talked to our pharmacists who are in the neighborhood and also our own pharmacists. And but I want to stress that what Silvio said. We did a lot of training in the beginning with all our nurses, so that all our nurses are speaking with the same tongue and not different, saying one says, oh, you are now getting the cheaper drug, etc. So we did not do this at all. But in the beginning, when the evidence was a little bit less, there was indeed a nocebo effect. But by now, my impression is that everybody has understood that there is a comparable efficacy and safety of the biosimilars. the nocebo effect has diminished. And also the really taking the informed consent and talking to the patients in the beginning has made a lot of change. So in the beginning, we wrote a long paper on nocebo effect, and then really the framing got more and more important in everyday clinic. And for me, now nocebo is not so much important anymore in my daily practice, but we are indeed challenging the new situation with the automatic substitution. But then I propose to have a meeting at, let me say, October, November, and then we can exchange our real experience with that. So now it's only a little bit, we don't know really what will happen. Hopefully not too much.
Yeah, it's an interesting time ahead, isn't it? And so it'll be a very interesting real world experiment when who knows what you're going to get when you go to the farm. Obviously, you're going to get the drug, but which form of biosimilar you get. And, you know, as Richard was saying, maybe the administration device, how are we going to, might that cause underdosing in some patients? It's an interesting time ahead. I suppose one thing you briefly mentioned it earlier, and I think we'll go back into discussing it a bit more now, which is adalimumab. My goodness, my pronunciations of monoclonal antibodies need a bit of work. So anti-TNF drugs, they've been used very successfully in the treatment of rheumatic diseases for quite a while now. But what new data are we starting to see on biosimilars in the real world and not just in clinical trials? Rika, do you want to start off on that one?
Actually, I think we are living in a very interesting time. And I proposed a title for a meeting at our German Society meeting in September. That means back to the future. I think we are in the situation to go back to the future because, of course, we all like small molecules. But we have the data from the oral surveillance study. And at the moment, there are a lot of limitations. We can't give it to patients with a history of thrombotic events, obese patients over 65. And so the data, despite the fact that they are somehow also inconclusive, it is mandatory not to put our patient at risk. And so also, as we saw in the presentation by Josef Smolin with the EULAR recommendations, I think there will be a revival of anti-TNFs. That is my personal prediction, in being really putting patients on the safe side. And if you have these limitations by the restrictions, then by the warning letters or red hand letters, then of course there will be more TNF prescription, I think, because we have the experience. I just looked it up this morning for another event, and we have nearly 30 years indeed of TNF experience now. That is quite a bit.
And Richard, what are your thoughts?
So I agree completely. I think it's good in many ways that we're seeing this. We have a tendency to get distracted by the marketing behind every new biologic, and not just the JAKs, so all of the other cytokine inhibitors as well. And we sometimes forget about our old trusted TNF inhibitors, which have the longest data, the best, most comprehensive safety data of all of our agents, and also work kind of across the spectrum of our diseases better than any other agent. And I think in many ways it'll be an advantage going back using a bit more of those. It'll be especially beneficial in patients where there might be some diagnostic confusion, and might be advantageous to use an agent that could address more than one disease, and also address some of the other manifestations which tend to come along with our diseases, such as inflammatory bowel disease or uveitis or other extra articular things.
And Silvio, from a gastro point of view, where are you all looking with the small molecules now? And, you know, obviously everything's exciting around the biologics and the biosimilars, but is there still that approach for small molecule drugs?
Yeah, of course. As I say, the rheumatologists are always ahead of us. Finally, we are going to get several JAKs that are already available since years in the rheuma field. But in general, I think that now PRAC is revising the label because of the safety concerns. So it's very likely that still TNF, at least in our field, will be the first entry fish. And very soon, also ustekinumab is going to become biosimilar. So we'll have a second MOA as a biosimilar drug, and this is going to make a difference. Probably doctors, at least in our field, will be more and more inclined to use an ustekinumab biosimilar rather than a TNF because of safety. And because, of course, we have only that indication as compared to RA for rheumatologists. But still, because of the safety and because of the what is going to happen, I don't know. We need to wait what is the revision of the label. But in US, as you know, JAKs are always after TNF.
I suppose, yeah. I mean, the JAKs may have a use in a gastro patient because I suppose the comorbidities with a gastro patient might be slightly different to an RA patient, so there may not be as much of the risks that you have to worry about with a rheumatoid patient and JAKs than
But
you might
this
with
is under
gastro.
discussion.
Exactly,
Exactly.
yeah.
Something
It's
under discussion at the moment.
interesting times ahead, certainly. Rika, you mentioned Joseph Smullen and the new EULAR recommendations that were presented at Congress. So I suppose let's expand a bit on what they're saying about TNFI drugs and where that might fit in with, I suppose, current treatment paradigms versus the other biologics that are available.
Actually, concerning TNFs, I think there was not so much new in the new recommendations, but what was new, and I pointed to this already last year in an article in Nature Review Rheumatology, they really followed the ACR. And that is, I'm really very happy with this. I did a lot of research on glucocorticoids, and we know that glucocorticoids on a long term do more harm than benefit. And this is why the new recommendation that glucocorticoids should be tapered rapidly and after 6 months should be stopped definitely is very much close to the American College recommendation, and also I'm allowed to say to the German recommendation published a little bit earlier, because we saw very nicely indeed by the Rapid Registry very early that glucocorticoids above 7.5 milligram really do raise the rate of infection exponentially. And this is why this approach to stop the glucocorticoids, and we can do this if we have, and if you look at the data, for instance, for all phase 3 randomized clinical trials, you see the disease duration is about 10 years. And more than 50% of these patients who are methotrexate inadequate responders are on glucocorticoids, and even up to 10 milligram. And this is the situation of many of our rheumatic patients, and that is not good. So I think, coming to your question, TNF, nothing new, only the order is a little bit elevated on the same level as the JAKs. But for me, the most important message of the new recommendations for rheumatoid arthritis is really tapering and stopping glucocorticoids.
And Richard, from your clinical practice point of view, what have you taken away as maybe what things might you change or might you look at differently based on the new recommendations?
Yeah, I'm not sure I would do much differently in my practice based on them. I think the two talking points were the steroid one, which Rika has mentioned, and the specifically saying that JAK inhibitors have issues with them, and maybe they didn't necessarily need to say that. I think it's probably a good thing that they did. The glucocorticoid one is interesting, and people have taken different perspectives on it. It is a rowing back from the previous EULAR recommendations. It's more negative towards glucocorticoids. A lot of people coming from the ACR perspective have kind of proposed that maybe it's not negative enough, that it's still allowing or suggesting the steroids can be used for a relatively medium term period, and perhaps we should be more use less steroids in our diseases. I'm not so negative about it. I think it's quite open. It says to use the steroids if you need them, but for as short a time as possible, which is very reasonable, and to stop them as soon as possible.
I was just going to say, how do you think those changes around steroids might impact with patients? I suppose maybe a lot of patients, they're maybe used to going in to get their steroid injections. Will they cope with that change?
I don't think it will change necessarily. Certainly not in in Ireland. In my practice, I think what my practice is very much within the scope of these. And I think if patients need steroids, if they need a short-term fix, that's still going to happen. And maybe if there have been people who've been a bit more lenient with allowing people stay on steroids or perhaps longer than they should, and when there are other options, and maybe it will reduce that, which can only be a positive thing.
Yeah, it's very interesting as a it's just interesting. It's an interesting area, I think. And we were talking earlier on about adalimumab. There we go. And there was a lot of information presented on it. But there are so many biosimilars out there from the same originator compound. So how do you, as clinicians, both in rheumatology and in gastroenterology, decide which biosimilars to use? Let's start off with you, Silvio.
I would say that is very complicated because the quality is very similar. Once the product is approved, they have undergone all the regulatory pathways. Sometimes the differences are minimal and are dependent on the citrate presence that may itch or not on the injection. Sometimes could be on the volume that may or not give more problems to the patients, but overall, each one can be used without any issue. And even, long time ago, we were discussing about price. Now, at least most of the prices are very similar. So sometimes is in the public hospitals is mainly driven by tenders. In my hospital, being private, I have everything available, pretty much at the same price. And at the end, it's very complex. It depends on sometimes on what the pharmacist has on batch, or if there is a specific issue related to itches of the patient, but or a history of injection with other biologics and so on. But otherwise, it's very difficult to choose one versus another. I'm curious to hear from my colleagues in Reuma what they do, because this is a tricky issue.
Richard, how do you make the decisions in Dublin?
Yeah, so I suppose there are these kind of 4 different issues. Probably there's the citrate, there's the volume, there's the device, and patient support program as well, which can differ between them and how good that service is. And I think there's 2 different groups of patients as well. There's the switchers and there's the first-time initiators. Switchers, I very much try and get the closest to what they were on before. So especially with adalimumab, there was one of the biosimilar devices which was very similar to the originator, so I pretty much used that. And I, just from my own gut feeling and seeing people who were switched to other different ones, I think it had a better retention when they were switched to that very similar product. For the people going on it for the first time, generally what I do is I show them a couple of different devices and that I'm happy with other aspects of, and let them pick. And sometimes they don't care, they toss a coin to choose between them. And sometimes they've strong feelings for one or another, for whatever reason they may have.
And does that, I suppose, that interaction with the patient and that kind of joint decision making, does that improve their retention, do you think, or their letting them decide which device is best for them? Do you feel it's quite beneficial to the patient?
I think for certain patients it is, and I think it's giving them a feeling of some control back. They have a disease which is taking control of their lives, and anything you can give them back about getting a bit of control over things is helpful.
And so, Rika, how do you make decisions? Well, you mightn't be able to anymore if the pharmacist is going to change for you, but
we are still able to do these decisions. And what I heard from my patients is that no citrate really matters, and volume also really matters. So when I get this feedback from patients, of course, I'm more prone to prescribe the citrate-free preparation. And so that is one advantage, I think. And I'm also convinced that the citrate-free, and we really learned this already in the clinical trials, by the way, where we did investigate this compound in a large number of patients. It really, there is less pain. There is less injection site reaction or pain. And this really matters to patients. The devices are more or less similar. They are all orange somehow, they look nice, they look beautiful. And sometimes if I have different devices in my fridge, I also do the same. I show it to the patients and give them the feeling of doing a decision. It is a little bit only fake shared decision, to be honest, but the patients like this. They always ask, what can I do else for my health? You know, that is what they want. This is what they ask. And when they have the feeling they can make the decision between device A and B, one is more orange, one more green, and the next one more yellow, that is good for them, you know. But for me, objective reasons are site rate and volume.
Yes, that's it, and that, as you were saying, that idea of shared decision making is quite good. Okay, so we're coming towards the end of our sort of roundtable discussion. It's not just about listening to the four of us talk. So if you have questions, please do put them in the question box and we'll get through to them. But it's a question I love to ask everybody. Oh no, no, there's two more questions. My apologies. I've made a little bit of a slip up there. In terms of pediatric patients, because we have mentioned juvenile patients earlier on, and in terms of pediatric patients, are the new adalimumab biosimilars suitable for these patients? And what special considerations do you have around your pediatric patients? So let's start off with Rika.
I think they are definitely suitable. And I have no own experience with the pediatric patients, but the data I saw at EULAR are very encouraging. I think for the pediatric colleagues, that would be really an additional benefit, I think.
And so, Richard, you were saying earlier that you have quite a few juvenile patients and there's a lot of emotional issues, but what are your thoughts on the adalimumab as a biosimilar for pediatric patients?
I might have misled you. I don't do pediatrics either.
Oh gosh.
But we do transition, so people coming from pediatrics to the adult services, and I think pediatric and transition patients, they always need more of a time investment in order to manage their care optimally. I completely agree. I don't see any issue with biosimilars. I think, like every other decision and conversation, we will need to invest more time than we would with most of our adult patients in order to discuss the various issues. But I think we should do that. I think it's a worthwhile endeavor.
And Silvio, do you have pediatric patients or do you have juvenile patients as they're transitioning over?
Yes, and I would say that at the moment we are treating them like adults, even though the data, I must admit, are very little, and we need to have more data because are reassuring. I don't expect at the personal level major differences, but still it will be nice to have more robust data on the pediatric population, just to give a little bit more confidence and some more security, even though I will not expect any issue at all.
Exactly, but it's nice to have more data, and particularly, you know, if you can stop a disease progression and give good quality of life to pediatric and juvenile patients. Right, so now it's my final question. So just anybody in the audience, if you have questions, feel free to fire them into the question box for the Q&A session. But one question I always like to leave people with, and it's important to all of you, I think, what excites you most about the future of treatment for your patients? Essentially, is there anything that you came away from the conference thinking, yeah, I'm very excited about that? So why don't we start off with Richard?
So I have two. I have one which has been something which has troubled me for a long time, and we seem to now be finally getting somewhere, and then I have a kind of a bit of an off-the-wall one as well. So the first one is polymyalgia rheumatica, and something where we had nothing really apart from steroids. We used a little bit of methotrexate and it didn't really work fantastically well. But now in the last year, we've had 3 randomized control trials come along. 2 of them presented at EULAR again. So we have the 18-month follow-up of the Bridge PMR study, which was rituximab in polymyalgia rheumatica. So 1 dose of rituximab, 1,000 milligrams at disease onset, and then no more rituximab, and proven steroid reducing effect out to 18 months now. And then there is trial of sarilumab, the interleukin-6 blocker, to go with the trial of tocilizumab, the other interleukin-6 blocker that was presented at ACR. And both appear remarkably effective in polymyalgia as well. So fantastic to finally have treatment options for a group of people who were stuck on steroids forever when we couldn't get them off them. And my off-the-wall one thing that really caught my attention was this topical sodium bicarbonate for gout, which seems like a crazy idea. So baking soda in topical form onto joints affected by gout, and remarkably it works. It works on top of colchicine, or kind of one of our standard gout treatments to treat acute flare, and that's seems to be something very cheap and easy that might make a dramatic benefit to patients.
Gosh, that is interesting, and particularly as we're seeing not so much more and more gout, but it's not an old disease as some people still think it is. Rika, what has you most excited about the future?
Actually, I think there should be more investment in assessing patient-reported outcome and giving time to assess patient-reported outcome, because in our whole system it is not reimbursed at all. And we had a meeting of the German Society of Rheumatology in April. There were around 300 rheumatologists in that room, and one of my colleagues asked who is regularly taking patient-reported outcome, and there were only 3 to 4, one half decided, who gave their hands. And so I think this really has to be changed. Otherwise, we can't do shared decision making. We can't take the patient on board, and then all what we are doing has no value really for the patient, because the patient do not understand. We do not listen to the patient, and so this should be reimbursed in the system. I think then all our drugs would work much better.
And Silvio, for you, what has you very excited about gastroenterology? Well, other than the fact that you're going to work with your rheumatology colleagues all the time now on all your patients, and the fact that biosimilars are working very well for you, but what has you most excited at the moment?
So something that is emerging, I don't know if rheumatologists said it, but for us now with excellent results is a combination treatment of biologics. So it's something that in naive patients, giving 2 biologics leads to doubling the effect size of the treatment effect. So this is something very remarkable, because we're not only symptoms, but also objective measurements with double mechanism of action. And I bet we are going to see more and more of these double effects. I'm sure that our colleague in Reuma are already doing bispecific antibodies. This will come also in IBD after them for sure. But the dual treatment, I have not seen data so many in rheumatology. So I'm curious to see
it's
whether
true.
this
There's
is
only one
something.
nanomolecule, which we envy you for.
Yeah.
So I think that's a good place for us to end the roundtable discussion. So thank you all for your thoughts. It's been really good. Now, it's not just about us talking. So if you have some questions, pop them in the question box. I have a couple. So one thing that I personally found quite interesting from looking at some of the EULAR was there was a patient who gave a presentation about how, a lot of patients have been around the houses and back again before they get their diagnosis, be it IBD, be it gastro issues, be it rheumatology. And so a lot of patients maybe particularly have a bit of reluctance in going to see their medical professional, and that can impact, I suppose, on their treatment as well if they feel they're not being listened to. So how, within your own clinical practice, do you reassure the reluctant patients who maybe has felt let down by the medical field in the past? So Richard.
Yeah, it certainly is a challenge for all of us that we need to address, and it's particularly challenging, especially in systems where you're under time pressure. As I think one of the things you need to give them is time. That people feel or have experienced not being listened to when they've been with previous physicians. The very last thing that you need to do is be rushing them and trying to jam them into a busy clinic. So I think we need to be able to give them time to properly address their situation, their concerns, and acknowledge their previous bad experiences, and really do our best for them.
And Rika, do you face this problem as well? And how do you maybe reassure your patients, or are there particular patients who are most at risk?
Yes, patients with rheumatoid arthritis still wait a year for the first appointment, a little bit dependent on their insurance status, but it's around 1 year for both groups. And for the patients with ankylosing spondylitis or SPA, it's even longer. It's nearly 2 years still. So if we see these patients who really are in definitely need, we try to propose to them a 5-day coming to the clinic in a daycare model. And these 5 days, they come at 9 o'clock in the morning, they leave in the afternoon, they get physiotherapy, ergotherapy, psychological counseling, and really also medication counseling. And this is called a Rheuma school, as I called it. And this is very good. And if they have done this for once, they are so much supported by the nurses, which are really very, very nice together with them. And they have time, you know, they have 5 days out of their work where they can learn everything about their disease. And if they have the need, they can repeat this after 1 year or 2 years or 3 years. And I think that is a very good model. It was closed, our daycare clinic, due to the pandemic situation. And you can't imagine how much the patients were really happy that it opened up again in March this year. And we are really overwhelmed by patients to come for this model, and also for the repetition courses, like in the Swiss Army, by the way. But I like this model also very much.
And Sylvia, with gastro patients, how, are there patients who you find who are particularly reluctant maybe to follow a treatment regime because they feel they've been let down in the past? How do you provide additional support to those patients?
I would say that in general, patients are very motivated. When they are sick, they try to comply to the treatment. The real issue is when they are well, in which they really start to be less adherence. I speak by myself as being a patient with reflux disease. When I'm sick, I take my pills and I'm very good. And then you start to not taking and so on. And I would say that motivation and explanation and talking is the key aspect. Nurses will play a great job on this.
And I suppose that idea of communicating with patients brings me on to another talk that I really enjoyed, and I would highly recommend, if you haven't seen it, to catch up on it, which was the importance of the placebo effect. So the importance in how we communicate to patients about what a drug is going to use, being careful in the language approach that's used, and in maybe not using negative terminology. So do any of you have within your clinics kind of practice of the languages that's used and how patients are approached? I know you were saying, Rika, earlier that all your nurses would use the same language. So could you give us some examples of that?
Actually, we train it with them. When they come to us, they have training courses with one of my deputies or other doctors, and they are really making play role. This I learned at OMRAC for shared decision making, for instance, that we are doing the situation, and then we do somehow an exercise. Somebody is a patient, and sometimes we do this also with young doctors, by the way, because they also have to learn to use the right wording.
Yeah, it was a really fascinating topic. Richard, do you have in the support teams within your clinics, is there kind of this approach on the way language is used or the way information is provided to patients that would maybe try and enhance their sort of psychological welfare, or just reinforce positive messaging around treatment?
I think I'm very much envious of what they have in Germany.
Yeah.
We have excellent people in our teams, but there's too few of them. We don't have enough resources. We don't have good access to this sort of training, and I think things are not as good as they could be because of all of those issues. And I also think there's been a reluctance by physicians to even consider this sort of placebo effect and maximizing that there's kind of been a dirty word among physicians, that we want this real biologic effect of the drugs. We don't want anything that we can't measure in the lab. And I think that's a pity, because it can be a very, very powerful beneficial effect for patients.
And Silvio, do you in gastroenterology work at trying to enhance the placebo effect, or yeah, do you, is it something that's looked at in the gastro field? It was a very interesting presentation at EULAR about this idea of enhancing the placebo effect in our patients. And I'm just wondering, from a gastro point of view, is it something that you explore?
No, it's something that we are not really at all exploring, but is a great idea. And as usual, the gastro will look after this and will try to adapt in their field.
So when Rika publishes her paper, you're going to send it to Silvio and to Richard.
Absolutely, please.
Yes.
That'll be how it works. Well, listen, that's all we have time for tonight. So first of all, let me thank our expert panel of Professor Dr. Rika Elton, Dr. Richard Conway, and Professor Silvio Denise for a fascinating conversation about some of the great work presented at the EULAR Congress. So I really hope that you, the audience, enjoyed it as much as I did. I also want to thank Viatris for their support and EMJ for facilitating the discussion. Finally, I want to thank you, our audience, for taking the time to participate, for your interesting questions, and for all you do for patients and the field. So if you enjoyed this webinar, do check out our archive and keep an eye out for those that are coming up. So the EMG Health website contains all sorts of interesting content, including podcasts on a wide variety of medical topics. Until next time, stay safe, stay well, and most importantly, stay curious. Goodbye for now.
Bye-bye.